Hello, everyone. I'm Dr. Angela Mattke, and you are watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. Twice per month, I host a show where we discuss common pediatric health topics with top experts from Mayo Clinic Children's Center in Rochester, Minnesota. Please join the conversation today by sending in your questions and comments under the Facebook Live video stream, and we'll try to answer them during the broadcast. Today, we'll be talking about pediatric palliative care and how it can help children with serious, chronic, or life-threatening illnesses. We have two guests joining us today. Dr. Brenda Schiltz is both a pediatric critical care and pediatric palliative care physician. Dr. Schiltz is the program director of the COMPASS program, which is the name of the Mayo Clinic Children's Center Pediatric Palliative Care Team. She is also assistant professor of pediatrics, the medical director of Child Life Services, and co-chair of the Pediatric Ethics Advisory Group. Our second guest is Audrey Manahan. Audrey is the chair of the Pediatric and Perinatal Bereavement Committee. She's also the co-chair of the Pediatric Integrative Therapy Work Group, and she's also the Complex Nurse Coordinator for the COMPASS team. Dr. Schiltz and Audrey, thank you so much for joining me today.
Thank you for having us.
It's a pleasure to have you here. I think I'm actually going to learn a lot about this and hopefully dispel some common misconceptions about palliative care and provide some insights to some families and people watching the show. So let's start off by, Dr. Schiltz, can you just describe to us what exactly is palliative care?
So palliative care is a philosophy of care. Many people are not familiar with the term, or they haven't heard of it previously, or maybe they've heard about that with maybe a loved one who was older, grandma, great aunt, or uncle, such as that. But for children, palliative care is really a philosophy of care where we focus on trying to make a quality of life as best as possible. This is usually in the context of somebody who has a serious illness. It could be life-threatening, life-limiting, or just chronic and very serious and difficult for the family to endure. And so when the palliative care team gets involved, we focus on how can we make this journey better. We know that this is very difficult for families. A lot of times it's very unexpected, and there's a lot of psychosocial issues that maybe don't always get addressed by the teams who are focusing on how to try to cure the underlying disease or trying to figure out how to save this child's life. We try to add that extra layer of support and add in all that extra psychosocial support and well-being, and try to focus on improving the symptoms that are distressing for the child and the family.
So do you work pretty closely then with the teams that are treating the underlying medical condition?
Absolutely.
Okay.
We do not replace any part of the team whatsoever. We work collaboratively with the team as a whole. We often help enhance some of the communication because families, as we get to know them, might confide some of their fears or their worries or kind of what the mother gut or father gut is saying, that they're worried that something might be happening. We'll hear their concerns and try to bring that forward to the team. And that way we can work very nicely with everybody and see how we can make a better experience for the child and their family.
Absolutely. As a primary care provider, I'm sometimes not involved with the specific treatment of some of those really complex disorders, but I know in the past I've worked with your team, and you guys have kind of helped include me in some of those discussions as well, which is fantastic.
Absolutely.
Yeah.
And we like to try to bring in the primary care physicians frequently, especially if there's big decisions that need to be made. Say a child is going through lots of treatment and those treatments aren't as successful anymore, and families need to make some decisions about, do they try some experimental things, or do they try to go to, a phase 1 trial where it may not be real clear if things are going to be helpful. And when the families are trying to make those decisions between quality of life versus quantity of life, we like to get involved and bring the pediatricians involved because they know these kids just as well as anybody else, and we can help make those decisions together.
Okay. What type of medical conditions would a child have would be included in considering palliative medicine and palliative care?
Most of our kids that we see suffer from some type of neurologic disorder. Often it can be either a developmental delay, a severe seizure disorder, cerebral palsy. Sometimes there's genetic things that happen when they're born with very abnormal genes and don't have normal development along the way. Often we see kids that have acquired serious illnesses. Sometimes it's cancer. oftentimes it's complex issues that kind of integrate together. So heart disease, lung disease. We'll see those kids that might have chronic issues that end up in the hospital frequently. Those are usually the ones that we see. Ideally, we'll see those kids early on so that we can go on that journey with the family as they go through good times and bad times. Sometimes we'd like to see those kids, even if we don't know them real early on, even if we're getting to a point where things might be taking a turn for the worse, we like to get involved to offer that support and focus on helping the family through tough times.
Yeah. As you come in early in their disease process, is it sometimes difficult to have that introduction to the Compass Care with the families, and how do you go about doing that? Aubrey, do you want to answer that question?
Yeah, it can certainly be more ideal to have time to build a lasting relationship with this family, but we certainly don't shy away from seeing families as late in the game as possible. And the providers that I work with are very skilled, and they can, really we are just there to help. So we're trying to ask what's important to your family, how can we be helpful right now, what's important to your child. So really, whether it's early or late, we're happy to be a part of the care team.
Who else, besides the patient, is going to benefit from palliative care team being involved? Aubrey, you want to answer that one too?
Yeah. So just like all specialties at the Children's Center, we're looking at the whole family. So we know that a chronic, serious condition that a child may have affects their entire circle. So whether that's siblings, parents, grandparents, who's ever caring for that child. So we're really addressing the needs of everybody. And so we want to look at the physical symptoms of a child to make sure that they're comfortable. And we look at then their spiritual needs and their psychosocial needs. But again, as we work with a child, we know that we're working closely with that parent as well, or if there's a sibling that's been there. So we certainly try to, of course, focus on the comfort of the child as the priority, but certainly, we're always taking into consideration anyone that's coming in and out of that room and who can be helpful, that we can be helpful with.
Okay. Mm-hmm. So a lot of the family members or siblings, you're working on connecting them with resources. So other things like therapy, or is there resources for siblings that you often are able to connect them to?
Mm-hmm.
Yeah.
Yeah, oftentimes we will get child life specialists involved. Oftentimes, as a child's condition is evolving and changing, families will wonder, how do I talk to the siblings? How do I let the school know what's happening or how things have changed for the child? And we can help navigate some of those tough conversations, or bring in some of our child life specialists who really have been trained on how to communicate effectively with other children.
Okay. Let's talk a little bit about the Compass team here at Mayo. So this is an example of a palliative care team that a lot of other hospital settings will have. So we can kind of equate or help familiarize other people that are watching about it. So what does our Compass team stand for?
So COMPASS is actually an acronym. It stands for Comprehensive Pediatric and Adolescent Support Services. We include pediatric palliative care in that, but it's also a little bit more broadly defined, especially because we really want to focus on support. We're not here to have an agenda, or some people think, oh, palliative care, well, that must mean the team has given up, or there's no other options. Right. And really, that is not at all what we're about. We're here to support the family, and I often tell our families, I want to be your biggest cheerleader, but I also want to be your shoulder to cry on when things are tough. And so that's why we took the approach of being a supportive team. We do have other components of COMPASS, which include integrative medicine, which is using some of the more alternative approaches to healthcare. A lot of our families are interested in those sort of techniques, just as they're wanting to focus on quality of life, that comes into play. We also focus on perinatal palliative care, so that if a mother gets pregnant and they discover that there's a serious anomaly or there's something wrong with the fetus, that we can provide support even before that child is born, to kind of talk through what can we expect once that baby is born, and what options do we have to ensure that the family wishes are followed. We also include bereavement care, so that if a child does pass away or dies, that the care after that child dies is still provided. Mayo Clinic still is here to help support families even after a tragic loss. And so bereavement care is also provided in there. And then we also partner with hospice, which I know we'll talk more about, but we provide a lot of additional support to hospices.
Okay. We have an audience question, which I think gets at a comment that you made just a minute ago. And the question is, when children start to become enrolled and be part of the palliative care team, do doctors stop other treatments or treatments of their underlying medical condition?
That's a great question. The answer is no. And part of it is, again, we are looking at the child and the family as a whole and thinking about what are the overall goals that the family might have for their child if they're facing a serious life-threatening illness. And sometimes families may choose to stop other treatments because they may view it as it's too painful or it's not going to bring them the goals that they're after. So a lot of times those decisions are things that we come to together. It's not because we say we're involving palliative care and everything else must stop. And in fact, we often say children can receive ongoing life-sustaining treatment all the way up to the very bitter end, if that's what the family's decision is. And palliative care can be right there alongside them the whole way.
Absolutely. Aubrey, this is a question for you. How does palliative care differ in children versus adults? Is there differences, or is it essentially the same?
There's some similarities, but there's certainly some differences. I think on the adult side, it's a far more short-term relationship, because again, with adults, it's more of a treatment course, and then maybe when that is no longer an option, that they begin a palliative course. But like Dr. Schiltz said, with pediatrics, we can come right alongside a very aggressive curative type picture for that child for treatment, and just provide that support, provide ongoing decision-making support as they navigate what that looks like for their child, and certainly symptom management if they're continuing to do aggressive treatment. And in pediatrics, we can come on board very early, perinatal consults, and maybe we're seeing that patient for a very short time during their life, or maybe for years to decades. There's been patients that we've followed for years and years, and there's really no end of life in sight, and we're continuing to support that family and maybe just seeing them on an outpatient basis every year, along with their other subspecialists, just to continue that support. But again, on the adult side, I think they have a very clear focus on it's after that treatment is maybe no longer an option, and then aggressive symptom management, like goals of care, things like that. So lots of similarities, but certainly when pediatrics, we come on a lot sooner. Ideally, we come on board a lot sooner than on the adult side.
Yeah, when it comes into bringing your team involved in the care, especially when we think a lot about our patients who have cancer or involved with hematology, oncology, is that part of the process where there's an automatic consult, or is that just a discussion that's brought up in ongoing conversation?
Often it's a decision, an intentional decision to bring us on board. We would like to be involved as early as possible, especially if we know that the risk of mortality is high, that we'd like to get involved as soon as possible, just to get to know the family well, know their values, what they're hoping for, and then we can sort of see the big picture. When families are going in to see the oncologist, they're looking at blood counts, they're looking at imaging studies, they're looking at very specific things. And what we'll often do is say, let's take a step back and look at the big picture. Remember 3 months ago, this is what we were doing, here we are now. Is this still okay? Is it not okay? And so that's kind of what we do. With oncology, we'd like to see them as early as possible and be integrated into their therapy.
Absolutely.
And certainly if that child does well, we can sign off. We've done that with other patients, particularly consults that we see in the NICU and the neonatology unit. When there's a lot of uncertainty, we come on board, we help navigate that. We just signed off on a patient this last week who is doing really well, who's going to go home with mom and dad. So there's no need for us at that point. But we've had that relationship, and should further complications or concerns arise, we can re-engage at that time. But with any patient, we hope that they would do as well as they can, and if we're able to sign off, that's great news to us too.
For those patients whose clinical course isn't going as well, and maybe we're starting to enter discussions about hospice care, can you talk a little bit more about either how palliative care differs from hospice care? Either of you can take that.
I can talk about that a little bit, because I think it's definitely a common misconception is that we're kind of one and the same, particularly when a patient does enroll in hospice and we continue to be involved. And certainly some of our intents are the same. But the difference between palliative care and hospice, so hospice is an insurance benefit. And so as an insurance benefit, there's eligibility. And luckily for children, under the concurrent care provision under the Affordable Care Act. Now, Medicaid programs are mandated to reimburse for both concurrent or ongoing aggressive treatment as well as hospice services. So that deciding, well, what are we gonna give up to enroll in hospice isn't always now the case for pediatrics. And so also with an insurance benefit, there's, in order to remain eligible, they have to show a certain decline. And a life expectancy of about 6 months when we're enrolling. But in pediatrics, we know that it's very difficult to give a prognosis. So some of that criteria is not quite as stringent when it comes to pediatrics. But versus our team with palliative care, we can come on board before the child's even born and continue to follow. There's no strict criteria to remain followed by the Compass team. As long as we're being helpful to the family, we'll continue to follow them for as long as we need to.
Okay. Are the services provided in hospice care going to be different than what you would do in palliative medicine?
Yes and no.
Okay.
Hospice is usually provided by a separate team.
Okay.
We partner with that team so that we stay involved and we know what's going on. But hospice usually has nurses, social workers, chaplains that will actually come to the home so that the children can be at home, not be running back and forth to clinic visits, etc. And that way they can really focus on their quality of life when they're at home. And so we partner with them to offer advice about medications or treatments that they might need during that time, and we just stay in touch for whatever the families need.
Okay. In adults, there's sometimes a separate entity for hospice, being an actual building where people may not want to go home today or aren't able to. Is there that same option for children if they don't want to go to their home?
There's not separate freestanding hospice facility in Rochester for children. We have had families that prefer to not have their child pass away at home, and so they will actually be in the hospital, and we can make that as comfortable as possible. There is other facilities outside of Rochester that can provide that kind of service.
Okay. And that's kind of been an area where there hasn't been a lot of options in the past, but it seems to be something that's developing more and more throughout the U.S. Is that right?
Absolutely.
More options for families for hospice care.
As medical treatment continues to evolve and become even more aggressive, even in the perinatal periods, we are able to keep kids alive that previously would never have had a chance. And unfortunately, with time, some of those kids will get sick or they will have complications. And because of that, they live longer than we anticipate. And so once it comes to the point where they no longer can survive, then they might need a facility like that to go to.
Okay. Switching directions just a little bit, we have another really good audience question. So many children don't have terminal illnesses, this person says, but they have more chronic illnesses. Do you apply some of the same principles of palliative medicine to help these families with children with chronic illnesses?
Absolutely. A big portion of our patients have chronic complex conditions. And this is something we are seeing more and more as children are able to live with very complicated needs at home. Some have tracheostomies with ventilators and feeding tubes. Some families run small ICUs out of their home. It's just amazing. And so we most definitely like to be involved with those families, to support them, and to help kind of go on those journeys, because we know there's lots of ups and downs with those families.
I'm going to switch gears again.
Okay.
All right. So let's talk a little bit more about how we talk to families and children, children that have chronic illnesses or life-threatening illnesses, and also their siblings about these things, because these are really tough conversations. How do you start those conversations, and what tips do you give these families?
Yeah, I can speak to that a little bit. So I think in pediatrics, often as providers, as adults, as parents, we want to shelter and protect our children from harm. But what we find, and what is most often the case, is that children are very aware of what's happening with their bodies. They're aware of the looks on the faces of the people that come into their hospital room or in their home. So they know that something serious is going on. And when they see a disconnect between maybe what they're being told and what they're seeing, it can cause maybe further distress for that child. So like anything in pediatrics, we're looking at meeting that child where they're at developmentally. So at least on the Compass side, when we're thinking about trying to connect with a child about maybe a new diagnosis or maybe a relapse or some new information about their health that might not be so good, having those difficult conversations it's not easy for anybody. But we always encourage parents to be honest and first of all try to understand what that child already knows. So we ask a lot of questions and we do a lot of listening in palliative care. So usually asking the child, what are you hearing from the doctors? What's your understanding about what that means? And we ask a lot about, well, what worries you then when you hear that? What are you most worried about right now? And it's amazing just with an open-ended question what you can get at. They might be preoccupied about their pet at home not being fed and they've been in the hospital for 2 weeks, or maybe they're having far bigger existential kind of concerns, but maybe it's something very simple that we can address right now. And then we always ask what they're hopeful for. In the setting of all of this, what are you most hopeful for right now? And it could be something that we can absolutely easily attain. Maybe it's a really big hope that may or may not be able to be attained, but even within that hope, maybe there's something that we can do with that child to help give them a little bit more sense of control, a little bit better understanding about what's going on, and so they can best prepare. We always tap our colleagues in child life. We think about chaplaincy as well, addressing the spiritual needs of children, as well as psychology if we need a little bit more of an ongoing support. And so the same would go for those siblings. So we're, again, looking at the whole circle around that child of who we can best answer those questions that they have. And typically, as we also are ready to just give a full barrage of information, so sometimes just a little bit at a time, and then re-engaging and continuing to have that conversation.
Okay. How about children, like you said, some who have some really good understanding about what their disease process is, and as they get older and older, how do you help families have discussions with the children about what they want going forward and what they want their care to include?
Absolutely.
Okay.
There has been times where parents are surprised by how much their child understands what's going on. There's been times where a kid will say, I know I'm dying, and no one wants to talk about it. And that's always a very humbling experience for everybody, and that's how we try to navigate those conversations. I know a lot of parents sometimes want to, as Aubrey said, protect their child and to protect them from the fear of what tomorrow might bring, because we have those same fears as well. It's very natural. But honesty is always best, and so we try to have that conversation. Sometimes we're the mediator between parent and child to say, how can we talk about what we want to do and what our goals are moving forward.
Absolutely, and it's going to be really age and developmentally appropriate, right, to determine who is going to, which children are really capable of making those decisions for their care, right? Okay.
Exactly. Right. And certainly if a child's been sick for a long time and they are aware of what's going on, they've been through lots of treatment, they are likely going to have a much larger say in what they do going forward. But regardless of what the situation is, we try to take the child into consideration always of what their wishes would be for themselves. Okay.
Aubrey, this is a question for you. How do you help children with their own grief? Let's talk a little bit about grief, and there's so many different types too, so if you could elaborate
absolutely.
that.
So in palliative care, we work a lot with families who are having anticipatory grief, so meaning that their child is still alive, there has been no death or serious loss in that way, but they're grieving all those little losses that's leading up to that child's death. So whether that's loss of developmental milestones or loss of being able to maybe make it to that next holiday or family gathering, or grieving the loss that they know those other surviving siblings are going to be experiencing. So there's so many losses that they're experiencing leading up to that death. So in terms of supporting that child, we've kind of talked about a little bit in terms of open communication, meeting them where they're at, a lot of open-ended questions in terms of what they understand and what do they want to know. And we really strongly look to the parents because we want to make sure we're honoring as a family what's important to them, and maybe that child does prefer to get all their information through their parents and not through the medical team, and that's completely fine. And we can direct the parents as best we can in terms of guiding them with honesty. Even Dr. Schiltz has even sort of role-played with parents, like, okay, I'm your child, how would you maybe break this news to them? Let's work out some of those details. And again, tapping all of our colleagues on developmental language that we can use. When there has been a death, in terms of supporting children with their grief, we talk about in pediatrics all the time that children are not just little adults. Children do grieve differently than adults. I think many people have an idea of sort of a linear process that we all go through, and there's sort of a set period of time that it takes to sort of overcome a loss. But when it comes to the death of a child, it's kind of all out the window, and there's not really a timeline. It's lifelong work for these families. But specific to children, we've got wonderful grief community supports here in Rochester through Mayo Clinic Hospice. There's community supports for the parents, but specifically to the children, there's a grief camp twice a year called Healing Adventures Camp. Because the key thing that we find with these children is that they feel like they are completely alone in how they're feeling. They feel like everyone else in the world is doing fine and they're really struggling, and they don't know if these are normal emotions that they're having or not. So that's one opportunity that they can have to be with their peers, feel like, okay, it's really normal to feel really sad in one moment and really angry in another, or actually feeling joyful for a moment and then feeling bad about it. So kind of normalizing some of that. Another thing that we're trying to do here is also just raise awareness for staff. So last November, November 16th is actually National Children's Grief Awareness Day. And I partnered with some colleagues in Child Life and Chaplaincy, as well as Mayo Clinic Hospice here in Rochester, to put on a Children's Grief Awareness Week. So again, it's just giving some simple information on some of those key differences on how children grieve, how we can best support these children, and that there's a lot of resources here in the community. So, and again, it's developmentally appropriate. So, you know, there's even that 18-month-old at home that's going to be grieving differently than that 18-year-old at home, obviously, and how we can best support them.
Thank you. That was a really great explanation. What about a bereavement? Let's talk about that bereavement process and how your Compass team can help with follow-up regarding bereavement.
Yeah, so Dr. Schiltz mentioned, so under the Compass team is the Pediatric Bereavement Program. So this is a new program to the Children's Center. So it was implemented when my position was created about 2.5 to 3 years ago. And what the program is, it's for all children, all families who have lost a child, who have had care here in Rochester. So this is not just for Compass families that receive this follow-up, so it's for all children. So what the criteria really is just 21 and under, and so I get these names through an automated list in the record, but it is a initial follow-up phone call within about 2 to 3 weeks to introduce the program, to assess for any immediate needs in the home, and then to implement then what will be a 2-year follow-up. And what that looks like are mailings over the course of that time with education, tailoring that family's sort of packet to where they live and maybe what their family structure looks like. If there's siblings in the home, what those ages are, maybe extended family that are close to that child. For all inpatient deaths, we've partnered with the Office of Decedent Affairs, and they introduce the program so that family can leave with the brochure that we have, so they know that this nurse will be calling you within a couple weeks. In the meantime, you're welcome to call her, so these families can call me as well. And then we've now that we've kind of rounded the 2-year with this program, we're implementing an evaluation, because we want to make sure that is this helpful? How can we improve this? What would have been something that we missed, or what was the best part about any of? Because we know that it doesn't just end at 2 years. So it's sort of an open door at that point, but the program, at least for the mailings, stop at about that 2-year mark. But I have some families that have kept in touch with me longer than that, and they have found that it's been helpful, so that's encouraging.
And really the door always remains open for these families. Just because their child is no longer receiving care and has passed away, we are still here to provide care, whether they want to talk. They want to talk with Aubrey, get resources for psychological or psychiatric care, whatever it is, just talk through what happened. We are always here for that.
Okay. Thank you. This has been fantastic. I just want to round up our talk today by talking about something new that you guys have been working on. Can you talk a little bit about that, the SMART program?
Yes. So we have been very lucky and fortunate to work with Dr. Amit Sood, who most people know him with his work regarding resiliency and stress-free living. He is an amazing pioneer who has done wonders in that field, and we said, let's bring this to pediatrics, because we know our families struggle with stress, particularly if their children are sick or chronically ill or are seeing us in palliative care. And so we said, let's develop this. So we will be starting to have weekly drop-in sessions on Mayo 16, where families can come and have SMART training to deal with stress and resiliency. And then we will soon be offering one-on-one appointments with families who can come see Aubrey or I, and we can tailor a SMART program that would be for their particular needs. So that is soon to come.
That is really
very
exciting.
exciting.
That's a very exciting offering to have, and I know that a lot of people, a lot of employees at Mayo have taken advantage of the SMART program and found it to be very helpful.
Absolutely.
So, well, thank you so much for coming today, Dr. Schiltz and Aubrey. It was a fantastic discussion, and I appreciate all your information that you shared with us.
Yeah,
Thanks for having us.
That's all the time we have. Join us next week for Ask the Mayo Mom, which will be on Friday, February 9th at 8:30 Central Time. February is going to be American Heart Month, and we'll be focusing on the pediatric aspect, specifically a type of congenital heart disease defect called hypoplastic left heart syndrome, or also known as HLHS. My guests will be Dr. Timothy Nelson and Dr. Sayur Qureshi, who, along with a multidisciplinary team of physicians, scientists, and other experts, are working collaboratively to find and apply innovative solutions for the treatment of HLHS, including use of stem cells and regenerative medicine. So we'll be discussing this along with many other aspects of HLHS. So please join us, and thank you everyone who watched today. Have a wonderful day.